We are live.
Good evening, everyone. Welcome to the iFocus online lecture number 491 of the refractive surgery module number 41. Today's topic is refractive surgery after corneal transplantation, which will be taken up by Dr. Navneet Sidhu ma'am. The moderator for today's class is Dr. Kanika Bharadwaj ma'am. Ma'am is currently an associate consultant in the Center for Sight in the Cataract and Refractive Surgery Department. Ma'am is involved in training DNB and PG students and also mentoring fellows. The chairperson for today's class is Dr. Swapnali Sabhapandit ma'am. Ma'am has done her MS from Regional Institute of Ophthalmology, Guwahati. She has completed her fellowship from LVPI Hyderabad and has worked there for 5 years as a consultant. She is currently heading the Institute of Ophthalmic Sciences at AIG Hospital, Hyderabad. She was the first person to conduct transplantation in the North Bengal at North Bengal Eye Center, Siliguri. She has actively promoted and pioneered corneal transplantation at Lion Eye Hospital, Guwahati. She has attended and delivered multiple talks at various conferences. She has been awarded with a G. Sita Lakshmi Award at Shankara Netralaya, Chennai in 2012 for her community work in corneal blindness and prevention. Welcome, ma'am. The speaker for today's class is Dr. Navneet Sidhu, ma'am. She's done her MD Ophthalmology from RP Center, AIMS, New Delhi. She is currently the Associate Consultant at Center for Sight, New Delhi, in the Department of Cataract, Cornea and Refractive Surgery. Ma'am has won gold medal in ophthalmology. She has multiple publications in various national and international journals. Welcome, ma'am. Over to you, ma'am.
Thank you so much for the kind introduction. So today's topic is refractive surgery after corneal transplantation. So as we know that corneal transplantation includes various different surgeries. It can be a full thickness surgery, which is penetrating keratoplasty, or it can be a lamellar surgery, which includes anterior lamellar surgeries or posterior lamellar surgeries. So anterior lamellar surgeries includes HALC and DALC, and posterior lamellar surgeries includes DSEC and DMEC. So as we know that primary aim of corneal transplant is to restore corneal integrity, transparency and shape. And to reach a good visual quality, optimal geometry of the surface needs to be attained. However, most of the times the second target is not achieved and results in tangible failure of the graft despite having a clear corneal graft. So what happens post-keratoplasty? Astigmatism and anisoconia are quite common. It prevents a good visual outcome despite having a clear graft, and it is usually hard to correct with spectacles or contact lenses. So what happens with contact lenses in such patients? They are usually difficult to wear and difficult to construct because of the irregular surfaces or because of the steepness of the corneal graft. And contact lenses may also be harmful in certain cases due to lesions or neovascularization at the limbus, since they might precipitate a graft rejection episode. So refractive surgery can correct both ametropia and astigmatism following corneal transplantation, and hence will help in improving the final visual outcome. So currently available modalities provide many options for patients intolerant to spectacle and contact lenses, and hence have helped in improving the visual outcomes in post-keratoplasty patients. So we have to consider various factors before, during, and after the surgery. So what are the various preoperative considerations that have to be kept in mind? So what was the original corneal pathology in such a patient in which we are planning for refractive correction? So the corneal pathology can be an opacity, it can be an ectasia or decompensation. Then the type of corneal transplant that the patient has underwent. It can be a full thickness penetrating keratoplasty or it can be a lamellar keratoplasty. What type of sutures were used, whether they were continuous, interrupted or mixed, and what was the timing of suture removal. And the type of refractive error that is present in this patient. It can be a purely sphere or a cylinder, or it can be a mixed type, or the patient might have myopia, hypermetropia, or a mixed type of refractive error. So, what are the indications for planning a refractive surgery in a patient who has underwent corneal transplantation? So, conventional methods of optical corrections have failed, and when there is significant anisoconia. And how do we plan the timing of surgery? We know that refractive stability is a prerequisite for any refractive surgery, and so is in such patients who have undergone corneal transplantation. And it usually takes 3 to 6 months after suture removal for the refractive stability to occur. And what are the post-operative considerations in such patients? So the post-operative considerations can be divided into plastic phase and the stabilization phase. So plastic phase is the early phase of post-keratoplasty, where the sutures are intact. And in such a phase, the graft is usually flexible. It can be easily managed by modulating the suture tension. And stabilization phase is the late phase when the graft architecture has become rigid, the sutures have been removed, and it's been 3 to 6 months post suture removal. And so such cases are usually managed by proper surgical procedures. So, what are the causes of refractive error in a patient of corneal transplant? So, preoperative causes can be that the host surface was irregular, and this usually is important in cases of lamellar keratoplasty, or there was irregular thickness of host bed or donor graft, and different densities of the host recipient and the donor graft. So these different surface features can cause post-operative refractive error. Intraoperative factors can be that the donor cornea wasn't handled properly, the centration and inclination of the trephine wasn't proper, or while suturing, the host bed and donor cornea were misaligned or not aligned properly. And the suturing technique is also very important. And post-operative causes can be wound dehiscence, graft infection or melting, or suture breakage in the early plastic phase. So why overall this happens is because with the graft, there is creation of a new limbus at the level of the scar of the host and the donor cornea, which affects the corneal curvature throughout the 360-degree circumference of the cornea. So looking at the host bed can have increased corneal curvature and or irregularity of the curvature, which can happen because of oval trephinition with slanting edges, as you can see in this diagram. So it will cause a difficult host and donor apposition. So how to prevent this? You can cauterize the host corneal apex before trephination. So any bulge or any irregular protrusion or ectasia will flatten out before trephination and will cause a circular trephination. And it is very important to include all of the pathological tissue in trephination, considering in mind the size of the donor cornea that we are planning to implant. And because of differential density of tissue, because of areas of thinning, melting, desmetocele, scarring, it all should be included in the trephination, specifically in the optical zone of the cornea. What are the factors of the donor cornea? So, radius of curvature of the donor cornea also holds importance. If we have missed any ectasias in the donor cornea or we have done a decentered trephination, it can cause post-operative refractive errors in the recipient. Also, increased diameter of the donor cornea, when there is a discrepancy in the donor and the host corneas, it can cause increased curvature of the graft because of the bulge and hence a myopic shift. And what can be the intraoperative causes? Again, as discussed, it can be a decentered trephination, non-perpendicular margins, larger diameter grafts, which causes increased curvature. Smaller grafts, on the other hand, will cause increased suture tension and also cause flattening of the cornea. So it will cause a hyperopic shift. So in such cases, more accurate trephination can be done by using a suction trephine or a laser-assisted trephine, in which femto laser is used for the trephination. And suture length, depth, and distance also affects the refractive result finally. So post-operative causes of a refractive error in such patients can also depend on the timing of suture removal. So sutures in a patient who has undergone corneal transplant should be removed as later as possible. Early removal can cause scar relaxation and hence will cause ectasia in the area of removal and scar relaxation and eventually thinning, which causes a myopic shift and irregular astigmatism. So how can we manage the cases in plastic phase? So the most common method is to adjust the sutures, and it is usually done under keratoscopic control. So we can adjust the sutures, in which single interrupted sutures can be placed or replaced, or a single running or a double running suture can be placed. The initial suture can be removed and fresh sutures can be put. So we can also time the removal of the sutures when a single suture or multiple sutures are causing hypertension or they have become loose. Or we can plan selective suture removal depending on the areas of healing and graft apposition. So in cases of tight suture or loose suture, it is essential to replace those sutures with a fresh suture since it is already in the plastic phase. It is in the early phase. And apposition of the suture. So it is not necessary that in a penetrating keratoplasty, you have to only put 16 sutures. You can put additional sutures also, which will help in graft host apposition. And continuous suture repositioning can also be done. So suture removal is mandatory in case of increased tension with flattening of the graft or loosening of the suture, which has signs of infection or ectasia, wound dehiscence, or neovascularization, since these will eventually cause a early graft failure. And how can we correct ametropia in the static phase? So there are various surgical techniques. We have curving techniques in which compression sutures can be applied so as to flatten the areas of steepness. Or we can also do a revision of the corneal wound where the graft host apposition junction, it can be cut open again and again sutured. So this is revision of corneal wound, or we can do a wedge resection. Then we have flattening or incisional techniques where we can give limbal relaxing incisions, or we can do arcuate keratotomies. Then we have laser-based techniques also, which is usually PRK or LASIK. And then we have lens-based procedures, which includes phakic IOLs or phacoemulsification with implantation of IOL. Usually we prefer toric IOLs. So what are the various curving techniques? So curving techniques include applying compressive sutures along the flat axis, which will cause a flattening in that area and will improve the final refractive outcome. We can also do revision of the surgical wound with reopening of the affected area and resuturing. Or we can do a wedge resection in which a crescent-shaped lamella is removed in the affected quadrant, and that area is sutured with slightly tighter sutures. Corneal incisional procedures are rarely performed these days because they have a lack of predictability, and there are no accurate nomograms planned to plan for accurate positioning of the incisions and their length. So arcuate keratotomies are one of the first refractive surgery technique to correct corneal astigmatism. But now they're outdated. We don't usually prefer to perform these surgery. So it is usually done by using a diamond blade or a Hana arcuate keratome, also called as a RC tome. It is suction guided keratome as shown in this picture. Or we can also plan arcuate incisions using a femtosecond laser, which is now preferred in today's time. So how do we plan the position of the incision? So incisions can be placed inside the scar on the host bed or inside the graft, depending on the type of refractive error and depending on the planning that we have done before the surgery. But they have their own risks and benefits. So incision inside the scar has a high risk of ectasia perforation because its scar is the area of the most weak area in the transplanted cornea. And it can also trigger an episode of graft failure. And if we plan incisions on the host bed, they have a greater unpredictability because the new limbus, which is created at the 360-degree circumference, it induces a variable that cannot be evaluated post-operatively. And incisions inside the graft, they are the most predictable and they give better results due to closeness to the geometric center of the graft, which is also the optical center of the eye. So how do we plan the shape of the incisions? So the incision can be trapezoidal, it can be a straight incision, or it can be an arcuate incision. So arcuate is the most corrective since this arch shape, it is more equidistant from the round scar and from the optic center, which allows to move the same amounts of tissue and also it acts at the same depth throughout the cornea and hence balances the force throughout the scar. So it provides a better refractive outcome, as you can see in this clinical picture. How do we plan the width of the incision? It is calculated based on the area of the scar with the greatest traction, which is the area of the greatest curvature on the topographic map. It must not exceed 90 degrees of extension due to the risk of destabilization of the transplant. And again, it can cause areas of weakness and might trigger an episode of graft rejection. How do we plan the axis? So incision axis is a steeper axis of the topographic map, as you can see in this diagram. And usually the axis is not symmetrical. So it is not necessary that two arcuate keratotomies will be present directly opposite to each other. They can be present along two different axes as well. At least 80% of the corneal thickness at the incision point should be obtained to obtain maximum flattening of the affected axis. Otherwise, it won't be of much help. And the distance between two arcuate keratotomies should be such as to respect the optical center and the optical zone so that the patient's vision or visual axis is not obstructed. So what are the various corneal laser-based procedures? So how do we plan the corneal laser-based procedures? It is usually advised in patients with moderate refractive error and sufficient residual stromal bed thickness. It is to be avoided in patients with marked peripheral vascularization, thin host tissue, or a graft thickness of less than 500 microns, in patients who have graft host junction ectasia, flat or steep corneas, which are usually less than 38 diopters or more than 55 diopters on keratometry, in patients who have graft overriding at the graft host junction, or there is a wound malapposition. So the types of surgeries that we usually plan are PRK and LASIK. So PRK is usually planned with mitomycin C. It is a surface ablation technique, as we all know, and it can be epithelium on or epithelium off. However, PRK in such transplanted corneas always has a risk of haze and graft rejection. So mitomycin C has been found helpful to decrease the risk of haze and decrease the risk of graft rejection, although it's not a foolproof surgery. And reduced risk of scarring can also be obtained using a wavefront guided PRK, although PRK also has now become outdated due to the risks of graft rejection. So LASIK is usually carried for correction of spherical error and regular astigmatism. So LASIK can be microkeratome assisted or femto laser assisted. However, microkeratome assisted LASIK is unreliable in borderline corneas, the corneas which are steep or flat or are irregular. But with microkeratome, it has been seen that better results can be obtained if the surgery is done in two steps. So step one involves cutting the flap to interrupt the graft scar. So this step itself reduces astigmatism by 15 to 20%. And then excimer laser ablation is carried out 15 days after the flap has been cut on the residual refractive error. So this has provided better results in many cases. So microkeratome LASIK, although has good results, but it has an increased risk of rupture at the transplant scar, which is the weakest area. And it is also associated with a high risk of irregular flap cutting, with especially in cases which have under or over leveling grafts. And there is a high risk of buttonholes in corneas with keratometry of more than 48 diopters, or free caps in corneas with keratometry of less than 38 diopters. So femtoLASIK is a better technique, is a better surgery since it's a programmable intervention. You can program, you can plan your surgery accordingly. Treatment can be interrupted intraoperatively in the event of problems like opening of the scar or loss of suction. So you can stop the laser in between. There is a less risk of free caps or buttonholes. The flap diameter can be set in the machine and it gives a more precise cut and a more regular cut. The depth of cut is programmable in a femtolasic case. It's the cut can be programmed from 90 to 120 microns and it is more accurate. The side angle, the inclination angle of the side cut can be decided for perfect repositioning of the flap. The hinge can be positioned anywhere based on conformation of the host and donor and not necessarily superior or temporal. And it can be combined with incisional surgery. So LASIK can be easily combined with arcuate keratotomies, which are also done through femtolaser. So operative considerations in LASIK, there are multiple points to be kept in mind. So the planned flap size for LASIK, it should be larger or smaller than the corneal graft. So this is to prevent flap initiation at the graft host junction. We don't want the flap to start at the graft host junction, since it can cause a episode of graft rejection, or it can also cause graft dehiscence. In larger flaps, the intersection of flap cut at the graft host junction may cause free caps or loss of crescent shaped tissue from the periphery. So it will also cause a loss of suction, or it can also induce refractive error later on. A two-step procedure, as discussed before, with creation of flap first, followed by ablative treatment after an interval, will allow for more time for corneal stabilization and a better refractive outcome. And we can also plan a customized ablation, usually wavefront guided or topographic guided. There are various lens-based procedures also to correct refractive errors in such patients. So it is usually carried out in patients who are unsuitable for corneal procedures or those who have a higher refractive error. So the prerequisite is that the anterior chamber depth should be more than 2.8 millimeters, and the endothelial cells in the graft should be more than 2000 cells per millimeter square. So the options available to us are of phakic IOLs, which can be anterior chamber IOL. However, AC IOL is unfeasible in patients because of a high risk of graft damage and anterior chamber reaction and inflammation. We also have the option of anterior fixated iris claw lens. It is easier to implant, although these lenses are also associated with a high risk of pigment dispersion and can trigger an episode of graft failure. And then we have posterior chamber IOLs. So in this, we have implantable columnar lenses, ICL, which correct astigmatism up to 6 diopters. However, the disadvantage is that if we have a wrong white to white or vault, it can damage the crystalline lens, or it can induce a chronic intraocular inflammation. So the next option that we have is of phacoemulsification with IOL. It is usually planned in patients with lens opacities. And we usually prefer toric IOLs since the grafted corneas have some degree of astigmatism, and toric IOLs will help us to achieve a better refractive outcome. So how do we calculate IOL power calculation in patients post-corneal transplantation? So most important is that the corneal power is used in the Virgin's calculation and effective lens position. So effective lens position holds an important role in calculation of the power, since it is the position at which the lens will be stabilized for later on also. And post-keratoplasty, altered corneal curvature causes an error calculation in almost all the cases. And usually we land up with underestimation of IOL powers and hence a poor refractive outcome. So what are the factors limiting IOL power calculation in such cases? It's the anterior corneal curvature, the axial length of the eye, the anterior posterior corneal radius ratio, and the central corneal thickness. So anterior corneal curvature, which is also the SIMK, is significantly affected because of disparity between donor corneal button size and host corneal trephinition size. Or maybe in corneas which have landed up with oval trephinations or non-perpendicular edges. Undersized grafts will cause a corneal flattening and hence lead to a hyperopic shift, whereas oversized grafts will lead to a central corneal steepening and hence a myopic shift. Also, the differences in corneal graft suture tension will lead to differences in the anterior corneal curvature. So the higher the tension, the flatter the central corneal curvature. How will axial length be affected? So after keratoplasty, due to differential corneal thickness and corneal architecture between deceased cornea and healthy cornea, there will be a variation of the axial length. And also the variable corneal graft suture tension will cause differential axial lengths when measured from different areas of the cornea. How the anterior posterior corneal radius ratio will be affected? It is mostly affected after endothelial procedures, especially in the DSEC cases. So what happens in endothelial dysfunction, such as in Fuchs corneal endothelial dystrophy, the cornea becomes edematous. It is thicker in the center. Unless large bullae are present, anterior corneal curvature and axial length will remain constant. Whereas the most affected will be the posterior corneal curvature, which decreases, it becomes flatter, and hence will cause a myopic shift. However, after endothelial keratoplasty, the edema resolves and the posterior corneal curvature it increases, and which will cause a post-operative hyperopic shift. as we can see in this diagram. This is the normal corneal anatomy with a uniform corneal thickness almost throughout the optical zone of the eye. However, in corneal edema cases, the posterior cornea becomes flatter and hence will cause a hyperopic shift. However, after DSEC or DMEC, the posterior corneal curvature, it goes back to its normal position or near normal position and becomes more steeper and will cause a myopic shift. And post keratoplasty also, post penetrating keratoplasty, we can try to achieve a near normal corneal curvature, although it's mostly irregular in almost all the cases. So, how central corneal thickness also varies. It is altered due to reduction in the corneal edema after endothelial transplantation. So, because of all these factors, almost all of the third and the fourth generation formulas are affected because they assume that there is a fixed anterior posterior corneal radius ratio. But in keratoplasty, post keratoplasty, the central corneal thickness and the curvature both changes. So, ray tracing methods are also affected because the corneal curvature measurements are taken pre-operatively when the cornea is still edematous compared to the post-operative status in which the edema has resolved. So there is a conflict of measurements. So the only biometric factor which is not altered following keratoplasty is the actual position of the IOL inside the capsular bag. So the constants as predictors of IOL position are different for various different formulas and hold importance in the formula calculation, such as the A constant for SRKT formula, which is specific for a specific IOL, or the surgeon factors for a holiday formula, pre-operative anterior chamber depth for Hoffer Q, and the three A constants as used in the Hagee's formula. So these constants are derived empirically from back calculations, starting from the post-operative refractive outcome and a given set of inputs, including the same ones that get altered during the corneal transplantations, which is usually the keratometry readings. But these constants are not reliable after the procedure, and for this reason, they ideally should be customized for all the cases, depending on the type of the corneal graft, the surgical technique used, the suture tension, the IOL model being implanted, and the surgeon's own factor. So, further sources of possible error to consider are that the donor corneas who have undergone LASIK or laser refractive surgery previously, or donor corneas with undetected ectasias. So, what are the methods to limit refractive surprises? We can plan triple procedures, which include simultaneous keratoplasty, cataract extraction, and IOL implantation. So, in penetrating keratoplasty or in DAL case, estimated post-op keratometry values can be taken from previous cases done by the same surgeon, or use if the surgeon can use a similar suturing technique, or with a similar graft or donor size disparity. It can also be avoided by using K readings from the fellow eye, which is unoperated or already transplanted. So this will help us achieve a better refractive outcome. In cases of DSEC or DMEC, third generation formulas can be used, and a myopic target of around 0.75 to -1 diopter can be aimed so as to achieve a good outcome. However, in cases of DSEC, most affected formula is the Hagee's formula, while SRKT is the least affected one. So we can prefer using a SRKT formula. And in all cases of keratoplasty, axial length has the largest impact on IOL power calculation. So it should always be measured by using optical biometry to minimize post-operative errors. And in aphakic eyes, so eyes which have undergone keratoplasty and cataract surgery but have been left aphakic. So in these cases, secondary IOL can be planned, which is usually placed in the ciliary sulcus after the graft has healed for a sufficient duration of time. We can also use ray tracing, which allows corneal and IOL power calculations from objective anterior and posterior corneal curvature measurements and axial length. In ray tracing, no adjustment or regression is required for special cases such as post-laser refractive surgery eyes. And it can accurately calculate IOL power in pseudophakic eyes, provided that the IOL position can be accurately measured. We can also use intraoperative aberrometry to provide accurate results, provided that the transplanted cornea is clear and it is possible to scan it well. So the following are the main drawbacks of implanting the IOL later after initial keratoplasty. So the aphakic patient has to cope up with poor vision for several months. It is often not possible to wear a contact lens immediately after surgery, considering various factors like graft healing, graft host junction apposition, irregular surface of the graft. Aphakic glasses may also be unbearable due to anisometropia. And the risk of secondary IOL implantation is that it may trigger a corneal graft rejection. So we have to have extended usage of steroid drops to reduce the risk of graft rejection, but the steroid drops might also cause a raised IOP in patients who are steroid responders. So how can we plan IOL implantation in already pseudophakic eyes? So piggyback IOL can be planned in the ciliary sulcus or in the capsular bag, or as a new primary IOL in cases of IOL exchange. To prevent interlenticular opacification, it would be advisable not to implant two hydrophobic acrylic IOLs in contact with each other, but rather combining an acrylic IOL with a silicon IOL, or rather using two silicon IOLs. ICL has also been advised as an alternative sulcus piggyback lens with good results in children and adults likewise. And in corneas which still have cataract. So in such cases, biometry should be done only when the refraction is fully stabilized after suture removal has been done. DSEC, in cases with DSEC, it is advisable to aid for mild residual myopia and comparing the standard IOL power calculation results with those of ray tracing. In patients who have underwent PK or DALC, third generation formulas can generally be used as a normalized with fairly accurate results. In very irregular corneas or irregular junctions, ray tracing may provide better clues. And in patients who have undergone DMEC or ultra thin DSEC, standard third generation formulas or fourth generation formulas can be used without any major adjustments. So to reduce the risk of triggering a graft rejection, the surgery should be done when the eye is completely quiet, there is no inflammation. Post-operative treatment with steroid eye drops should be tapered slowly over several weeks or months, especially after penetrating keratoplasty or a DALC surgery. So how do we measure the net corneal power? So measurement of both the anterior and the posterior corneal surfaces is essential to get a net corneal power, which can be measured using ORB scan, pentacam, or OCT, which work on different mechanisms. So ORB scan is a placido disc and slit scanning, which measures the elevation and curvature of both the anterior and posterior corneal surfaces, whereas pentacam is a rotating Scheimpflug photography system of the corneal front and back surfaces and also measures the central corneal thickness. So the equivalent keratometry at the recommended 4.5 mm zone, optical zone of the cornea, will accurately measure the true corneal power. And the most reliable is the OCT, optical coherence tomography, which measures both the anterior and the posterior corneal power and gives a true estimate of the net corneal power. So the clinical outcomes. LASIK is effective for refractive correction after PK or DALC, with up to 20 to 61% cases achieving accuracy within plus minus 0.5 diopters unaided. Topography guided ablation has good outcomes, especially in highly irregular corneas with significant higher order aberrations. Epithelial hyperplasia and stromal remodeling may pose some challenges during the treatment planning, and the case can be individually planned. Phakic IOL implantation is effective with 50 to 71% cases achieving accuracy within plus minus 0.5 diopters, with 33 to 88% achieving UCVA of 20 by 40 or better. And the complications associated with refractive surgery after corneal transplantation can be, as discussed, buttonholes or free flaps or incomplete flaps, decentered ablation, epithelial ingrowth, flap displacement, undercorrection or overcorrection, graft rejection, delayed visual rehabilitation, increased stromal haze and scar, or regression of the transplanted cornea. So my take-home message for today's class would be that it is necessary to accurately study every case to select the best surgery possible. It is essential to consider the risk of failure or damage to the graft with the surgery that we are planning. And the patient should be adequately informed about the risks and benefits of the surgery proposed. Possibility of regraft should be explained in all cases of surgery in the event of a failure or graft damage. Enhancements by mean of femtolasic or PRK with mitomycin have shown to give excellent results with a low risk of triggering a graft rejection. And leaving the eye aphakic after corneal transplantation and aiming for secondary IOL would provide the most accurate results. However, it is very debilitating for the patient and poses a serious risk of triggering a corneal graft rejection or damaging the corneal endothelium during the secondary IOL implantation, and therefore it is usually not advisable. In cases with severe refractive errors, the best approach is by either replacing the IOL in early cases or by placing a piggyback IOL in the sulcus after calculating the power using the refractive vergence formula or ray tracing. Thank you so much.
Thank you, Dr. Navneet. That was a very elaborate and yet very crisp presentation on a topic which could be as vague as this. May I invite Dr. Swapnali ma'am to please give her expert comments on the topic?
Yes, as you correctly said, Kanika, I think Dr. Navneet did a very good job. I was actually looking forward to this presentation to see what the material will be because the scientific evidence is very less, extremely less. So the timing, when I went through the literature, it is as vague as 8 months after the procedure up till 3 years. So I think we have to titrate and decide based on the preoperative condition and the post transplant condition of the patient. We can be doing it a little earlier in the ultra-thin DSEK and DMEC cases. DSEK, yes, we have to wait for the hyperopic shift to stabilize. That usually happens by around 6 months. And in optical and DALK cases, yes, once the sutures are removed, we have to keep repeating the corneal topography and see whether there is a stability in the astigmatism, the irregularity and the astigmatism. Maybe once we have 2-3 scans which are done at a gap of a month or 2 months, then we can plan a refractive procedure for such patients. What is your take on that?
Correctly said, ma'am. I have not yet done any refractive procedure for a post touched up cornea patient, in which we can include anything that could be even the mildest of the things, such as a PTK or something like that. But I have yet to encounter someone. Yes, of course, I have come across a lot of patients of keratoconus who have had some kind of intervention done, and post operatively, after a few years or months, they have this wish that if they could get a little bit better quality vision, because they're not only struggling with the number, they're also struggling with their glasses. The quality of vision is not that good. So we have done ICLs, customized ICLs for such patients in few scenarios, and they've been very happy. But my go-to I would say treatment option for such patients is to either give them a recent advancement of these specialty contact lenses like
Yes.
the spherical lenses, because they are less damaging to the cornea. They give good quality vision without the risk of, landing up into a transplant failure or another corneal procedure which may be required at a later stage. Even if we plan something, ma'am, generally we leave the cornea untouched, and we generally go towards the lens-based procedures in
Yes.
such cases.
Yeah. For a very high myope optical PK case, I had done one PRK, but the haze was quite significant. So my main worry was will there be an epithelial rejection or, one stromal rejection in such case, but there was none. So my only experience is with that one case, but there was significant haze. So after that, I think I would still prefer contact lenses, as you say, because these are grafts. So they are like, very precious tissue. If someone is very firm, then yes, better to do something in the lenticular part rather than touching the cornea. And then again, what Dr. Navneet said, that it is to be done in a combined 3-stage procedure. If there is even an early hint of lenticular opacity, is always better to combine the keratoplasty with a cataract extraction with an intraocular lens. And later, maybe we can do the titration with contact lenses and give the best vision to the patient.
Correctly said, ma'am.
Yeah.
Uh, Very, very, intriguing topic this is, I would say, because not a lot of people who have undergone corneal transplantation procedures have that much guts to go through another refractive procedure. For them, their corneas are very precious and they do
Yes.
take. We also have a subset of patients who are not very cautious and they land up in clinics with a lot of infections and loose sutures, broken sutures, loss of follow-ups and all. Ma'am, I would like to ask if such a patient turns to your clinic and you know the patient is not going to follow you properly and they live far away or they have some economical,
Hmm.
financial reasons,
And compliance issues also. Yes.
issues, ma'am. So, would you let the patient decide on a refractive procedure, or would you ask them to just manage something conservatively instead of going for another procedure? Because all said and done, we still have the risk of rejection in any kind of secondary procedures. So, what would
True.
be your that?
So I would say that the risk of rejection is in both contact lenses as well as a procedure. But then the chances of rejection with a contact lens, until and unless it is very badly used, is much lesser. So in those patients, I would prefer a contact lens. But yes, maybe phakic IOL, or if the patient needs a cataract surgery with an IOL, still I would go ahead. But refractive surgery on the cornea, it would be my third option, the last option in such cases, because we need to see these patients after touching a transplanted cornea again and again. So if the patient cannot come back, so it's better to go for a contact lens or an intralenticular procedure.
Yes, ma'am, correctly said. Dr. Navneet, we have the newer technologies like the transepithelial keratomelusis and other procedures where we are talking about just improving the topography as a refractive procedure instead of completely, negating the refractive error that is there. So, your take on that in such post-keratoplasty patients not happy with the quality of vision and having a lot of astigmatism issues, can giving them a little bit of lesser number be a better option in such cases? Or what's your experience on that?
I feel these procedures they will be helpful in patients who have a lower degree of refractive error or in which the astigmatism is not much. Since the transepithelial ablation will also cause some amount of haze in at the interface and can also induce higher order abrasions, which these patients already have. So the already present higher order abrasions they eventually do not provide a very good post-operative outcome after transepithelial ablation, and hence in my personal experience I do not prefer that surgery. And in all my experience, all these years of experience, I prefer that such a patient be managed in the early plastic phase, where it's easier to manage by suture replacement or resuturing or improving the graft host apposition. So eventually, 6 months or 1 year down the line, these patients have a better refractive outcome, even with glasses or contact lenses.
Correct. Dr. Surveen, do we have any questions on our online platforms?
Before that, can I just add one thing? So when you go for the suture removal, what we have seen that nowadays, because we have placido-based, corneal topography, that works better than a central keratometry reading.
Yes, ma'am.
So yeah, so it's better to do a placido-based. We do not need a posterior curvature. We don't need a pentacam or an op scan. A simple NIDEC or a simple TOMI placido-based topography is always better to do the suture removal selectively.
Selective suture removal or replacement, it's much better.
Is much better. True.
Ma'am, we have few questions here. There's a question which states that what are the complications that we should look out for post-refractive surgery in a corneal transplant patient?
So the biggest risk is the risk of graft rejection. We have to closely monitor any signs for graft rejection or ectasia or wound dehiscence. So basically, first thing is that steroids they have to be continued for a longer time in such patients. And along with the steroids, we have to monitor the intraocular pressure as well as intraocular inflammation also. Since post-op, these patients usually become relaxed with their medications, with their follow-ups. So it is essential to reiterate the fact that the patient has to be very diligent with the medications, with any signs of rejection like redness, pain in the eye, decrease in the visual acuity. So basically, that graft rejection has to be carefully looked for and managed.
Okay, ma'am. There's another question regarding the ablation and treatment zone size. What should be, how much smaller it should be post transplant in post transplant patients?
So as I discussed also, that the flap size or the ablation zone, it should be measured according to the graft size. It ideally should be smaller or larger. It should never be equal to the graft host graft size. It should always cross the graft host junction, or it should be limited roughly 2 to 3 mm before the graft host junction, because the margin, it can be irregular.
Okay, ma'am. Ma'am, are there any data regarding the about graft rejection? What are the chances? Is it more in cases of PRK patients or in cases of LASIK patients?
So PRK patients, they have a high risk of post surgery, post treatment scarring as compared to rejection, whereas LASIK patients, they have a high risk of rejection as compared to scarring. Because LASIK, it involves the anterior stroma. The intervention is done at the level of the anterior stroma. So there is a high risk of stromal rejection. PRK, whereas the risk can be reduced by the use of mitomycin 0.02% for at least 30 seconds. However, PRK will not give good post-operative refractive outcomes as compared to LASIK. There is no such defined literature data, but with the cases that have been done till now, the risk is definitely higher in LASIK.
Ma'am, we don't have more questions.
So, regarding the rejection and the complications, there is a very good systematic review which came out in 2023. It kind of summarizes the studies, small studies which have been done throughout the world. But again, if you see the variables in the rate of rejection, rate of complications, it varies throughout the studies. So we do not have a clear-cut answer, but what Dr. Navneet said kind of summarizes what is to be expected in such cases.
I think we've already discussed all the factors, and Dr. Navneet, that was an excellent presentation, and I'm sure it must have taken a lot of effort to compile all these things, because it's like ma'am already mentioned, it's not very well given in literature or even in scientific research. I think this is one topic that probably we should look forward to research in future, and amazingly done. And thank you, Swapnali ma'am, for your expertise and your precious time. It was a very good session. So many new things to learn actually for us as well. Because
Yes.
in day-to-day life, we are stuck with the conventional things, and this is just out of the box thinking. So, great session. Dr. Surveen, you've checked all the other platforms. Do we have anything on Facebook?
I think there's
I
one
think
more
we have,
question. Yeah.
yes, ma'am, we have another question. Uh, it is, should we do LASIK in DALK patients?
So, LASIK can be done in DALK patients since the depth of the junction, it's quite deep. Like LASIK flaps are usually cut at 90 to 120 microns. So there should not be any problem in DALK patients, just that the flap size should be managed as per the graft size.
And it's better to
Okay,
do a femto because the suction pressure is much lesser.
Yes,
So
ma'am.
femto is much safer in these cases.
okay, ma'am.
Ma'am,
Ma'am,
anything you would like to add, or should we call it a day?
I think we can call it a day because such a niche topic and so much have been discussed. I think there's nothing more to discuss right now. It was a wonderful presentation. Dr. Navneet, congratulations. I really enjoyed your presentation. And thank you, Dr. Kanika, also for putting all those, good inputs. And I hope the postgraduates really benefit from this discussion.
Thank you
Thank
so
you.
much.
Thank you, ma'am, for
Thank
the
you, ma'am.
discussion. Thank you. Thank you, everyone.
Okay,
Thanks so
goodbye.
Thank
Bye.
you, ma'am.